Hey everyone. Thank you guys for coming today. There are some sign-in sheets over here. If y'all are doing extra credit or anything like that, please sign in. And then also there's coffee in the back too, so help yourself for that. My name is Corey, and then me and Kelsey Thomas are presidents of Appalachian ADA. And on behalf of Appalachian ADA and the psychology department, Robert Whitaker is here with us. So just a kind of a quick bio. He is the author of 5 books, 3 of which tell the history of psychiatry. So his first is Mad in America, Bad Science, Bad Medicine, and Enduring Mistreatment of the Mentally Ill. And it was named by Discovery Magazine as one of the best science books of 2002. His second book on this topic was Anatomy of an Epidemic, which some of you guys have read, I've heard. Magic Bullets, Psychiatric Drugs, and the Astonishing Rise of Mental Illness in America. And this won the Investigative Reporters and Editors Book Award for Best Investigative Journalism in 2010. And this book has been translated to 9 foreign languages, so pretty impressive. And in his latest book, which he co-wrote with Lisa Cosgrove, Waller Fellow at the Edmund J. Safra Center for Ethics at Harvard University, is Psychiatry Under the Influence, Institutional Corruption, Social Injury, and Prescriptions for Reform. And he is also the founder of madamerica.com, a website that features research news and blogs from an international group of writers interested in rethinking psychiatry. So without any further ado,
this is on, right? Yeah. Well, first of all, it's a real pleasure to be here. I want to thank Josh and Carl for inviting me. It's the first time in Boone. I have to say I'm so happy to come down here. It's been a miserable month of weather in Boston, and I get here and it was snowing last night. Wasn't expecting that. So here's what we're going to do, really what this talk is about. One is societies organize themselves around narratives. So societies organize themselves around a particular narrative in psychiatry that's been promoted really for the last 35 years. We'll look at that narrative, and then we'll look at the science to see if the science supports that narrative. So in many ways what this talks about is how we have different, if you look at history, for example, there's different narratives in history that you can find. And one of the things that I think what's so great about being in an academic environment sometimes is digging beneath the conventional narrative and seeing if there's something underneath. And that's really what we're going to be doing today. So I'll talk for about, I think, an hour and a half, a little bit more than an hour and a half, and we'll have time for discussion. So there's a very strong conventional narrative that you can read in, are you hearing an echo? Yeah, okay. That you can read in books like, this is a book, History of Psychiatry. Edward Shorter is a very famous historian at the University of Toronto. And the conventional narrative begins like this. In 1955, a new drug came into asylum psychiatry, asylum medicine. It was called chlorpromazine. The brand name is Thorazine. And in this conventional narrative, this drug initiated a revolution in psychiatry comparable to the introduction of penicillin in general medicine. Now, if this is true, there's been few advances in medicine as important as the introduction of penicillin in general medicine. So, of course, that's an antibiotic. It's a magic bullet that kills bacterial infections. And so he's putting this first antipsychotic in that same category of medical advances. And then this is the first drug that gets remembered as an antipsychotic. And you hear the word antipsychotic as if it's a specific antidote to psychosis. And then we get antidepressants, and we get anti-anxiety agents, and this is seen as starting the modern era of psychiatry. And it kicks off, they say, a psychopharmacological revolution, a great advance in care. Now the second moment, so we get these drugs in 1955, this first generation of drugs. Then in 1980, and this is seen as a second landmark event in this new narrative of psychiatry, the American Psychiatric Association publishes the 3rd edition of its Diagnostic and Statistical Manual. And when they publish this 3rd edition, they make a big break with conceptions of mental illness in the first 2 editions. So if you look at DSM-1, DSM-2, There's a lot of Freudian ideas about what causes mental distress. A lot of sense that these are psychological problems. There's a core group of biological ailments in DSM-1 and DSM-2, but most of them are descriptions of psychological problems. And then with this book, DSM-3, what the American Psychiatric Association does is it adopts what it calls a biological model or biomedical model. It's actually a disease model. Now it's going to take all of these many, many different sort of experiences we have of distress, anxiety, depression, mania, kids not behaving well in school, and they are going to be conceived of as diseases. And whatever the distressful things are seen as symptoms of a disease. Now, Jeffrey Lieberman, when he recently wrote a book about this, and he says this is the book that changed everything. And he says, this is the most important book, he says, that's been written in the past 50 years. And he didn't mean just in psychiatry. He meant this is the most important book that's been written in the English language in the 50 years in terms of how it is reshaping our society. I agree. This is the most important book that's been written in a long time. Because what it does, in essence, is it causes us to reconceptualize what we expect of children. When children are struggling in some ways, so often now we give them the diagnosis of ADD begins with this book. There was no attention deficit disorder, ADHD, prior to this. It's conceptualized first time in this book. So we're going to start seeing children who are not doing well in school through this lens, and a lens of disorder. And the other thing that this book did that was so different, that such a break with history, is this. If you look in all medical textbooks, say for example depression, there used to be an understanding that there was some core thing of depression that some people got, where they got a deep melancholy where they couldn't get out of bed, and it lasted and lasted, that was out of sync with life events. In other words, there's no triggering life events that explain why this deep melancholy had descended on somebody, where it was at such length of time out of sync with the life events. When you got depressed or anxious and you had things going on in your life, like you're getting divorced, losing a job, having, dealing with poverty, that was seen as a normal reaction. But now they're going to take all of those other emotional distresses and now they're going to recategorize them as diseases. So this is a big change as well. So this is published in 1980, and this becomes the new thought. There was a famous book called The Broken Brain, written in 1984 by Nancy Andreasen. She was the editor-in-chief of the American Journal of Psychiatry. Can you all read this, by the way? So this is the conceptualization that's now going to be behind the DSM, how we're going to think about psychiatric distress. As you say, the thought was that each different illness has a different specific cause. There are many hints that mental illness is due to chemical imbalances in the brain, and treatment involves correcting these chemical imbalances. Do you see what's going on here? That things are in the brain. The problem is in the individual. So it's not between the in-between spaces. It's not because, you've lost your job, or you're getting a divorce, or you're breaking up with your boyfriend, girlfriend, those life events, because those are environmental causes. This is going to say it's the chemistry of your brain. So this is a big, different way to conceive of human beings. Now, once this happens, here's what happens ever since that time. The APA, following the publication in 1980, decided to beef up its public relations capacity. It started a new public relations arm. It began to get funding from pharmaceutical companies to begin to sell this disease model to the public. They began doing campaigns to reach out to the media. They had annual media awards. They had training of psychiatrists in terms of how to speak to the media and talk about this new model. And here's the story they've been saying ever since. Major disorders are diseases of the brain. Psychiatric drugs are highly effective and safe. And psychiatric disorders are underdiagnosed and undertreated. And they basically have been selling this story with different campaigns ever since the early 80s. And by the way, they have done this so successfully. Anybody know what percentage of Americans now take drugs on a daily basis, psychiatric drugs? 1 in 8? For adults 12 and older, it's about 1 in 5. So that is a dramatic, something new in our society to have 1 in 5 adults on psychiatric drugs. And of course, now we use psychiatric drugs all the way from 5-year-olds on out. So this is a big change in society. Just tells you how effective this was done. And this is the key part of the story. So in 1980, they published DSM-3, and right away you start hearing that in fact they are finding that mental disorders are in fact due to chemical imbalances in the brain. Now I could have picked out a quote from every year here, right? But I just did it periodically. And you'll see, 1981, clinical depression is caused by a chemical imbalance in the brain. And by the way, look who the spokespeople are. University of Chicago, great medical place, right? I mean, these people making these comments have standing in our society. You'll see 1988, he's the former president of the American Psychiatric Association. This is a comment 2001, and look at 2001. 88, antidepressants fixed the problem. 2001, we now know, it's not a hypothesis, that mental illnesses such as depression or schizophrenia are not moral weaknesses or imagined, but real diseases caused by abnormalities of brain structure and an imbalance of chemicals in the brain. This is an announcement of a scientific discovery. We know, okay? It's not a hypothesis. And you'll see this, antidepressants restore brain chemistry to normal. The 2005, this is pretty funny actually. So in 2005, the American Psychiatric Association did a survey of the American public to see how many Americans now knew that chemical imbalances cause psychiatric disorders. And this whole story was successful. Something like 80–85% of Americans said they now knew that depression was caused by a chemical imbalance. The one thing the APA was not altogether happy about was they didn't know that psychiatrists were the ones who were experts in diagnosing and prescribing it. So they put out a press release saying, they developed this whole thing. Let's talk facts about depression, antidepressants correct this imbalance, and who should you go to a psychiatrist because they're the experts in this disease. You just go forward 2014, you still can find websites that say this story. Okay? Now this is, by the way, a story of an extraordinary medical success. Think about how complex the brain is, and now you've identified the very molecule that's amiss in depression, whether it's amiss in schizophrenia, and you can fix it. In my opinion, if that story is true, that's the greatest scientific medical discovery of the 20th century, because of how complex the brain is. And that's what we're being told happened. Okay? By the way, I was just so you know, I began covering medicine as a newspaper reporter in 1989. That became my specialty beat. So I used to write about this all the time. So we've made this discovery. Now the final part of this story is that we got a second generation of psychiatric drugs that are so much better, more effective and safer than the first generation. The first such drug that came to market was Xanax. It's a benzodiazepine for treating anxiety disorders. We used to have drugs like Valium and Librium. In the 70s, they were understood to be addictive. When Xanax comes to market, it said it's a non-addictive anti-anxiety agent. You're all too young to remember when Prozac came to market. Prozac came to market in 1987, and it was treated as this amazing miracle drug. It could make you feel better than well, and just to give you an example of the enthusiasm around it, the pill itself was featured on the cover of news magazines. I think New York Magazine had it on the cover, I think Newsweek had it on the cover. This was seen as this extraordinary advance. And you could read articles saying that our knowledge of the brain was such that we could tinker around with the molecules and we could almost maybe even give you a designer personality. And there were even some hand-wringing about the problem may be we're going to be so good at this, we're all going to be running around so happy that sort of sadness will disappear, sort of a philosophical sense of this. But this was how this was heralded, that we could give you the personality elements you want that make you feel better than well. And then in the mid-1990s, we got new antipsychotics, Risperdal, Zyprexa. They were called atypical antipsychotics. And they were said to be at least as effective as the old drugs like Haldol, but they didn't cause the side effects, etc., that the old ones did. These were seen as breakthrough medications too. So this is the story that we have organized our care around. This is how we see our children. Anybody know what percentage of youth in America are diagnosed with ADHD? Any guesses?
7.
think the latest is 13%. So I'm just using that number to give you an example of how much this narrative has altered our thinking. For example, when I was young, we just didn't have that way of thinking about students. So very successful. How about spending on psychiatric drugs? In 1987, as a country, we spent about $800 million on psychiatric drugs. Anybody know what we spend today per year? Any guesses?
5 billion.
5 billion. Any others? It's 40 billion. So it's a 50-fold increase in spending on psychiatric medication. So what I'm trying to give you here is this narrative has really gripped hold of American society. And I actually do a lot of traveling, and increasingly this same story has been promoted around the world as mental health has been globalized. So that's the conventional narrative. Now what we're going to do now is to see if the science supports that narrative. And what you're going to see here is there is a counter-narrative that you can dig out from the scientific literature. And here's really the parts of it. First, when you have a big medical advance, you usually expect that the burden of that illness in your society will hopefully go down, right? So for example, that when you get an antibiotic, people stop dying from bacterial infections. You get a polio vaccine, etc. But theoretically, we should see the burden of mental illness going down, right? Instead, I'll show you this data. It's soared during this time of the psychological revolution. The second part we'll look at is, did the chemical imbalance theory really pan out or not? We'll just see what science said. What did they find about how the drugs affect the brain? And then third, we'll look at this. We'll see if as people, when those new drugs came to market, and stories that were being told, do they fit with actually the science? Or in fact, was there a great exaggeration and corruption in what was told because of financial influences that were present? And here is what, in fact, is the newest part of this. This is what I wrote about in Anatomy of an Epidemic, because it raises a whole new question. We approve drugs in this society because they're effective over the short term, right? They knock down the target symptom better than placebo over 6 weeks. That's how you get a drug approved past the FDA. But if you're taking a psychiatric drug for 2 years, 5 years, 10 years, what question do you really want to know? How does it shape your life over the long term? Is it improving outcomes over the long term? So we'll look at that as well. And when I wrote about this in 2010 and tried to figure out what the science was saying, one of the reasons that book got a lot of attention was because it was the first book that really tried to say, what is happening to people over a longer period of time? So this is just the data on the number of people disabled by mental illness in the United States, sort of as a marker of the burden of mental illness. Now in 1955, there was no Social Security program for taking care of people who couldn't work. So basically the disabled mentally ill were seen as those in mental hospitals, okay? That's where they got care. There was no group homes, there was no residential care. At that time, there were about 550,000 people in state and county mental hospitals. But you've got to look at the data. They were also functioning basically as nursing homes. There was a lot of neurological patients. There was 350,000 people with a psychiatric diagnosis. So you take that number, look at the population, and that produces a disability rate of about 1 in 500 people. Okay? Now, in the 60s, we deinstitutionalized. We start discharging people from mental hospitals, long-term care, and we set up a program for caring for people in society where they get on disability, either SSI disability or SSDI disability. So what other researchers have said, if you want to track the number of disabled mentally ill in our society, from the hospital days to the community care days, you should look at the number of people on SSI and SSDI, and the people who were declared eligible because they were disabled by mental illness. Okay? So you look at that, and you find by 1987, we have about 1.25 million adults on disability by 1987. You look at the population, and that's about 543, or about 1 in 200 disability rates. So it went up. And this is the era of the first generation of psychiatric drugs, okay, from 55 to 87. Prozac comes in here, and this is when we get this extraordinary expansion in the use of psychiatric medications. They're supposed to be so great. And you'll see that now we have about 4.5 million people, adults on disability due to mental illness. So, as this psychopharmacological revolution has unfolded, rather than see a reduction in the burden of mental illness in our society, we've seen a great increase. Now, this does not prove anything. It just raises questions, right? Because normally when you have a great medical advance, you're not going to see this. But it's just a starting point to question that narrative. Last little thing, how about kids? How many kids were on receiving a disability payment due to mental illness, 18 and under, in 1987? Any guesses? There were 16,000 people in the United States that were kids seen as disabled by mental illness. Now we have about 700,000 kids disabled by mental illness. In other words, they're getting a payment. And if you look at the kids who go on disability as children, about 2/3 when they hit age 18 and just go on to adult disability. So it's as if there's a new career path that's opened up in our society where kids get diagnosed, medicated, on disability, and basically you see this life sort of evolves. Okay, the scientific origins of the chemical imbalance theory. This theory did not arise from understanding what was going on in the brains of people so diagnosed. So it didn't arise from investigations into depressed people or people with schizophrenia. It arose from an understanding of how the drugs acted on the brain. So in the 1960s, if you look at the antidepressants, well, first of all, what did the researchers learn? They learned how neurons communicate in the brain in the 1960s. So you have a presynaptic neuron. This is how two neurons communicate. Okay? You have a presynaptic neuron that will release a neurotransmitter, a molecule we call a chemical messenger, into that gap between neurons, which we call the synaptic cleft. And then that molecule, it might be serotonin, it might be dopamine, it might be one of the other neurotransmitters. It then binds with receptors on the receiving neuron, which we call the postsynaptic neuron. And we say that molecule fits into those receptors like a key into a lock. You've all heard this, right? And that's how messages get passed. And now, in order for this messaging system to work, the brain has to have a way to remove that molecule from the synaptic cleft, and it removes it in one of two ways. Either an enzyme comes along, metabolizes that neurotransmitter, breaks it into metabolites, and the metabolites are carted off as waste, or the molecule goes back up into the presynaptic neuron via reuptaking channels. And that's how it gets removed from the cleft. So here's what they discovered in the 60s. Antipsychotics work by blocking dopamine receptors. So what that means is the drug, the compound, sits in those receptors, doesn't activate them. It's like you're pouring glue into the lock, okay? You're blocking that receptor. So in that way, you're thwarting the passage of messages along the dopaminergic system, right? Because you're gumming up those receptors. So they said, aha, we're limiting dopamine activity. We're blocking dopamine activity. We're hindering. Maybe schizophrenia is due to too much dopamine activity. In other words, the hypothesis is going to be born that we find what the drugs do and we're going to hypothesize that the problem is the opposite. Does that make sense? So if you look at antidepressants in the 60s, they worked in two different ways. One blocked serotonin and a group of compounds called norepinephrine. It blocked the reuptake process of serotonin into the presynaptic neuron, or they block the enzyme that metabolized those serotonin. Either way, what it meant is that serotonin and these other class of neurotransmitters, they stayed in the synaptic cleft and longer than normal. You're upping serotonergic activity, right? So you're going to hypothesize that depression is due to the opposite. So that's how the hypothesis gets born. So now in the 70s, they began doing tests to see if people with depression, for example, before they went on an antidepressant, did they have a deficiency in their serotonergic system? And one of the ways they did this was this. Remember I said that one of the ways you remove serotonin from the cleft is you have an enzyme that metabolizes it, and the metabolites are carted off as waste? Well, those metabolites will show up in the cerebrospinal fluid. So researchers hypothesized, well, people who are depressed, if they have too little serotonin, then they're going to have low levels of metabolites in the cerebrospinal fluid. So they measured those levels, and what they found is that there's basically a bell curve of metabolite levels in people with depression, and it's basically the same for people who aren't depressed. These bell curves overlap each other, right? So then they said this, well, not everybody responds to an antidepressant. Maybe it's those at the low end of that metabolite level are the ones responding to antidepressants. And the NIH does a trial, and here's what they found. Again, they found no abnormalities in the metabolite levels. They also found no correlation between metabolite levels and response to an antidepressant. So in 1984, can y'all read this? So what are they saying? Doesn't look like it's panning out. All right, then in 1987, Eli Lilly brings Prozac to market, and they market it as a selective serotonin reuptake inhibitor. And now is when we really start to hear about this chemical imbalance story. There's more and more studies. Is there something wrong with the serotonergic system? And here's what the American Psychiatric Association concluded in its own textbook in 1999. Now, if you read this statement, it's a bit scientific, but they're reviewing the history here is what they're saying. They're saying this is, the hypothesis was born based on the action of antidepressants, okay? That's where they're saying the hypothesis was born. And then this statement, however, inferring neurotransmitter pathophysiology from an observed action of a class of medications on neurotransmitter availability is similar to concluding that because aspirin causes gastrointestinal bleeding, headaches are caused by too much blood loss, and the therapeutic action of aspirin in headaches involves blood labs. You see what they're doing here? They're actually making fun of the hypothesis as not not really very well founded right from the beginning. Because there in fact is no reason, just because you have a drug has an effect, that means the pathology is the opposite. Read the bottom line. Additional experience has not confirmed the monoamine depletion hypothesis. Serotonin is a monoamine. They're burying it here. They're saying we didn't find it. Now remember, I'm just going to go real quickly back to this. What are we learning from 2001 from Head of ABA publicly? Their own textbooks are saying it didn't happen, and here we're reading that we now know that these are true. Anyway, I'm just going to go. This is Stephen Stahl's a famous psychopharmacologist. He writes a book. This is a textbook taught in psychiatric departments. And he says, there is no clear and convincing evidence that monoamine deficiency accounts for depression. That is, there is no real monoamine deficit. It's not true. The investigations into the dopamine theory of schizophrenia are a bit more complicated. There's still some research that maybe in moments of psychotic events you get some sort of increase, at least in some people, in dopamine release for a time. But they're not saying that the dopamine system itself is abnormal. Anyway, Stephen Hyman is a neuroscientist at Harvard. He was also former director of the NIH, so he addresses the dopamine theory of schizophrenia, which is that it's caused by too much dopamine, and you'll see he says, there is no compelling evidence that a lesion in the system is a primary cause of schizophrenia. He's burying that part of it. These are the two twin foundations of the chemical imbalance theory. Now, Kenneth Kendall was one of the world's most well-known investigators, co-editor-in-chief of psychological medicine, into this whole hypothesis, and in 2005 he says this: we have hunted for big, simple neurochemical explanations for psychiatric disorders, and we have not found them. Here's my favorite quote of all. This is Ronald Pies, is a psychiatrist who's the former editor-in-chief of the Psychiatric Times, which was like a publication of the American Psychiatric Association. He writes in 2011, in truth, the chemical imbalance notion was always a kind of urban legend, never a theory seriously propounded by well-informed psychiatrists. Well, I'll say, I know Pies pretty well. The question is, who was proposing it? It wasn't by, you saw this was by the head of the APA, so it's their own guild of students. I'm just curious, how many of you have heard of the chemical imbalance story? You see the problem here? The problem is we were being told a marketing story and not a scientific story, but it was passed off as a scientific story. So a man named Daniel Carlin was on NPR's Fresh Air. They had this thing saying, is it really true that the chemical imbalance story didn't pan out? They said yes. So then they asked the psychiatrist, well, why did you tell your patients this? And here's, I'll just let you read this. This is really revealing. This is remarkably candid. He's saying, I lie to my patients so they think I know something. But he's acknowledging that, in fact, they don't believe it themselves. So anyway, we set them this counter narrative that we're going to look at. The very first point we're going to look at is that does this fundamental part of the conventional narrative, that they discovered that chemical imbalances were due, that major mental disorders were due to chemical imbalances in the brain, which the drugs fix, you can see here it doesn't hold up. It's a story that's good for marketing drugs and getting people to take it. By the way, you know how I first began the questions? Because as a medical reporter, I wrote depression is caused by low serotonin, blah, blah, blah. And then I was doing a series for the Boston Globe. And everybody was telling me about, oh, these drugs are like diabetes for insulin, insulin for diabetes, they fix chemical imbalances. So I said, actually to Jeffrey Lieberman, I said, can you just point me to the papers where you found this to be so? I just want to read the actual science. And he said to me, well, we didn't really find it. I said, what do you mean you didn't find it? I know it's true, just tell me the picture. He said, no, it's a metaphor. I said, I understand, like, insulin for diabetes is a metaphor. Just tell me the paper. He said, we use that metaphor to get people to take their medications, which we know are good for them, but it's not really true. And I couldn't believe this, and then I called other people, and everybody told me the same thing. It's just a metaphor. And I'm pretty sure, though, the public doesn't understand. It's just a metaphor. So, if the drugs don't fix chemical imbalances in the brain, what do they do? This is a paper by Stephen Hyman in 1996 when he was director of the NIMH. And he wrote this. Here's how we should think about psychiatric drugs. The first thing they do is they create perturbations in neurotransmitter functions. So, an antipsychotic, what does it do? It blocks dopamine receptors. An antidepressant blocks the normal reuptake of serotonin into the presynaptic cleft. And what he's saying is all these drugs block some normal function of neurotransmitter activity. Right? Now he's saying the second step is this.